My name is Bryn Rhodes. I'm a CTO of Harmonic. I've been involved with quality measurement and decision support standards within HL7 and FHIR for the last several years. In this presentation, we're going to talk about quality improvement and measurement with FHIR. So what are the aspects of FHIR that can be used to perform quality measurement and to share the descriptions of quality measures? So we'll start with the quality measurement with FHIR, and I've given this presentation before. It's at DevDays, so it's a little updated, but I apologize if some of the material is duplicate. So quality measurement. So what's a quality measure? It's a quantitative tool to assess performance of an individual or organization related to a specific process or outcome. So there are lots of different kinds of quality measures, but in general, what we're looking for is to identify whether or not we're doing a good job, right? According to for some definition of good. So an e-measure is then the digital, or an ECQM, e-clinical quality measure, is a digital computable representation of that. So HEDIS star ratings, ECQMs that are used with Centers for Medicare and Medicaid Services program measures, those all use a digital computable representation, so that in the best case, I can take that representation, it's basically the description of a report, and I can run that on my system, right? I don't have to manually build the queries and have developers build out the infrastructure to do that reporting. That's the goal of that computable representation. So they're typically evaluated at a population level, but they can also be evaluated at a patient level. So I can say, is this patient in or out of care as prescribed by this particular measure? So lots of different types of measures. You have process measures that focus on whether or not a particular process is being followed. An outcome measure, for example, a measure that evaluates cancer screening rates. That's a process measure saying we've already decided that cancer screening is a good thing, and so we want to make sure it happens. On an outcome measure, we're actually measuring the outcome of some actual treatment. So a measure that evaluates improvement in asthma control, for example, would be an outcome measure. A structure measure is something that focuses on a healthcare provider's capacity, so number of beds in a hospital or things like that. Patient-reported outcome, something that you're actually focusing on the results of surveys or questionnaires from the patient themselves. And then a composite measure is one that's made up of multiple measures. So a wellness measure, for example, might consist of multiple screening measures. Okay? So within all of those different types of measures, you have measure scoring types. So these are standardized approaches to characterizing the measurement to make it easier to do analysis and comparison between measures. So a proportion measure is just, I've got a numerator and a denominator. It's just a rate, and I cast the measurement in terms of that rate. So an example is the proportion of patients that have been appropriately screened for breast cancer. A second type is a ratio. It's very similar to a proportion, but I can actually have different criteria and members for numerators and denominators. And then a continuous variable is one that actually measures some element. So the A1C value as it changes, or the median time to admission for a discharge. Median time from admission to discharge for an ER visit. So those are just standardized scoring types. These are identified by the, and then within each of those scoring types, you have different criteria. So you have initial population, which is the overall set. So this is all of the people that we want to deal with. And then you constrain that set to smaller and smaller pieces. So in a proportion, you define the initial population, the denominator, and the numerator. In a ratio, this diagram is showing just a proportion. In a ratio measure, you can have different denominators that are subsets, and they can be disjoint or they can even overlap, depending on the use case for your measurement and how you want to actually pull that together. But in a proportion measure, the initial population, the denominator is a subset of that, and then the numerator is a subset of that. And then you also have ways to pull different exclusions and exceptions out, mostly to adjust for kind of risk and if you want to calculate in different ways. So the reason we define these criteria, they're basically different buckets that you can use to explain this measure. So I can say the numerator is A1C, or the denominator gives a kind of framework for talking about the different types of measures. So another important distinction is patient-based versus episode of care-based. So your initial cohort might be all of the patients, but what you're actually counting in the measure may actually be encounters or procedures. So even though you're generally patient-focused, the actual elements or cases in your quality measure may be defined by an encounter. Maybe you want to see that on all encounters a particular procedure was performed. And so what you're actually counting may not be patients, and so that will affect what your score is. For any of these, the important takeaway is that for any particular measure, all of your criteria will return the same type of thing. So if you have a patient-based proportion measure, then all of your initial population, numerator, and denominator will describe sets of patients. Whereas if you're talking about an episode of care, all of your numerator and denominator and initial population will return sets of encounters, right? And that's to enable not only talking about and describing the measure, but so that an implementation that's actually running this measure knows how to actually run that and perform the calculation. So when we're looking about how do we describe this and share, we take components of a measure. We take metadata, that's kind of all the things about it. So it's identifier, who wrote it, when did they write it, who endorsed it, what's the evidence behind it. All of those types of things are part of the metadata. And those are really important for publishing and governance of the content, but they don't really impact the calculation. So then there's the structure of the measure, what population criteria are involved. So if it's a proportion measure, what is the numerator, what is the denominator? And those are described in terms of pointers into expressions that we describe in the logic. So the logic itself is where you define what the criteria is for each of these populations. So within a particular measure, the logic is represented using CQL. So we have libraries that describe the terminologies involved. You'll see the parameter indicates the measurement period. So if I want to start, typically when you run a quality measure report, you're giving it for a particular range, a given year or maybe a quarter. By parameterizing it, we now can just provide that as part of the evaluation. And then this context patient indicates that all of the criteria that you define within this measure will be evaluated in terms of a single patient. And that's a hook for the implementation engine to know how to actually run this. So it understands then that all of these criteria apply, and it needs to use the relationships of the data to the patient to feed the data, to feed the calculation. So looking at initial population for this measure example, in this case we're looking at the breast cancer screening measure. The initial population is just that is female and is age 52 to 74 at end. So one of the things you can do in CQL is give descriptive names for the criteria that you're defining. So each measure will have expressions for all of the top level criteria, that are then made up of more detailed statements about what that criteria actually means. So in this case, the initial population is those two criteria, and those are defined in terms further of is female, is the patient.gender is female, and the is age 52 to 74 at end. We just use a calculation to pull the age and do a comparison there. So that's pretty straightforward representation. Then in the denominator and numerator, we define the denominator is the same as the initial population in this case. We don't introduce any new constraints. And then the numerator is that the initial population and that they have had a mammogram. And that mammogram is that there exists a procedure that has been completed within the time frame of the measurement period. So we're referencing in this criteria the actual measurement period, and that gives us 2 years before the start to the end of the measurement period. So we're going to dig in a little bit further into this, into the actual query there. So this procedure in the mammography value set, that's a data retrieve within CQL. So anytime you see those brackets, that's a retrieve, and it's composed of a type and a value set. So the type tells you what kind of resource you want to pull back, and the value set tells you what codes you're interested in that set. All data access in CQL is organized into these layers because it gives a clean separation between the logic of the measure and the data that's required in order to run it. And so that can be expressed in terms of a data requirement. There's actually a data requirement type in FHIR that lets you specify that data requirement abstractly, and then what I come away with from a measure is a set of data requirements, and I can, by static analysis, look at the set of those data requirements and determine what data is needed in order to get a successful evaluation of the measure. So in this case, it's simply interpreted as retrieving procedures for the patients that have a code that's a member of that mammography value set. So then in that criteria where we're actually looking for the date range, it's a little further than that, where we say we actually have the ability to parameterize those data requirements. So you can say that the data you pull back depends on the value that you passed into the evaluation. So in that case, the data requirement itself isn't static. It becomes a dynamic thing that you have to ask for the data requirements depending on what value you provide to that parameter. So if I run it for 2016, my data requirement is that I need the procedures for 2016 and before in order to get an evaluation. So that's another way that we communicate the requirements for a measure is using profiles. So one of the things that in logic, when you reference the status and the performed, in FHIR, the procedure resource allows you to characterize performed as either a date time or a period. And we would either have to say if the proc performed is a date time, then treat it like this, or if the proc performed is a period, then treat it like this. Or in our case, what we did was constrain using a profile on procedure the values that are allowed for performed to only be returned as a period. So we say to satisfy this measure, the procedures that you send need to have a performed, and it has to be expressed as a period. So there's some question about who actually does that transformation. Maybe the data on the EHR is not conformant to that profile, so maybe there's a transformation that happens in transit, or maybe the EHR using this profile, produces that data in that way. That's an open question. At the very least, what we're trying to make sure is that we describe those assumptions that we make about the logic so that it's at least computable whether or not you're going to be able to get a valid response. and there's some communication about that. So then once we have this evaluation, there's a measure report resource that actually gives you the results. So you can run that on an individual, you can run it summary, or you can run a patient list report. An individual runs the measure for a particular patient. It just tells you for that patient whether they're in or out of each of the populations. With measures, you can also stratify, so you can define stratifiers along things like age or gender, basically any criteria. And you can also provide supplemental data. Supplemental data is additional information that you would provide with each member of a population as part of the report. So you can see the structure of the measure and the measure report. They're very similar, where you can, in a measure, define any number of population groups, and within each of those populations, you have the criteria. And then when you run this on the summary, the actual populations will just have the counts for the number of individuals in each of those populations. And then the patient list actually gives you the measure report for every individual in the population. So these roughly, if you're familiar with the current reporting stack for quality reporting data architecture, or document architecture, sorry, that this is modeled on that Category 1 and Category 3 reports. So one of the questions that we looked at on this HEDIS measure as we were going through it is, can we do better? Can we, like, HEDIS measures are based on claims data, and one of the things we're trying to figure out is how can we use clinical data to improve the quality measures that we're using. So one of the things, we were looking at this at Digital Quality Summit last year, and one of the things that we asked was whether we could use BRCA mutation, which indicates that if that mutation is present, then there's a higher risk for breast cancer, and so you should start screening earlier if that mutation is present, according to the guideline. So using that clinical data, I mean, it's not likely to be present in claims data, but if I have access to clinical data, so we can say that procedure, does that procedure exist, or is there an observation on file that patient has that mutation, or is there a family member history? If their sibling or parent has that mutation, maybe they have it too, right? And so we're able to express those using FHIR and the clinical data, those additional criteria. So then the refined BCS measure says that's an additional screening, and that if we have that additional mutation result, then we shift the screening window down 10 years, so that we're screening for that earlier if that mutation is there. One more difference there is that you'll notice we're using common, and so one of the things that we've done here is take the logic that's common to this measure and its associated decision support and pulled that into a common library so we can share that between those two. So, so what we have within the decision support is to say, at the point of care, does this patient need screening? And this comes back as, so one, we have to make that prospective, because we're not looking for whether they had, we're looking for whether they have. And so we kind of shift that window down a little bit, and we use the same exclusion factors, and then we back off 3 months in order to allow for scheduling, right? So you need to look for whether they've had it, because by the time they've missed the window, it's too late, right? You want to make this prospective so that you're not missing an opportunity. All right. So some of the other things that we've looked at for what can we do with this, the components now within FHIR that we have with quality measures. So one thing that's often done is gaps in care. So these screening measures are used to perform analytics on a population and determine whether there are measures that patients will fall out of, right? And so it's kind of a prospective use of the quality measure to say, create a gaps in care report that says you've got this population, there are these set of people that are not in the numerator and they ought to be, right? So that gaps in care report gives you a way to turn that into a kind of a care management tool rather than a retrospective quality reporting tool. So we've defined in our FHIR a care gaps operation that lets you run all of the measures for a particular patient based on topic. So you provide the topic and you say, I want to run all the preventive care and screening for this particular patient. And what that returns then is a care gap report, which is a document bundle where the composition just links to all the measure reports, and then each measure report provides the results for that patient. So you have breast cancer screening. They're in the initial population in the denominator. They're not in the numerator. So this patient then has care gaps. So those are reported through that. So another approach we're looking at is measures as a query. A population measure, a quality measure, is really just kind of a report. It's structured down into very specific results for scores, so you can compare scores. But what we're actually doing to get to that score is collecting a lot of data and looking at a lot of interesting things. And so one of the things we want to be able to do is pull that data. So instead of asking for the score for a measure, give me the data to calculate that score. And so that's a collect data operation that we've defined to say, for this measure, for this patient, or for this measure, for this population, give me all the data that would be required to pull that down. And then there's a last updated parameter to say, was that a question?
Yeah, would that be something like a risk assessment that somebody wants to do on a patient that's in a quality measure, like PHQ-9 or CHADS-VAS?
Yeah, you could certainly do a risk assessment. You could use this to pull the data that you needed for a risk assessment. You would just define the library of data or of expressions that were the inputs to the risk assessment that you needed. For something like PHQ-9, where you have a questionnaire, if the patient has a history of filled out questionnaires for that, you could pull that, yeah. But this isn't going to, it's not going to like invoke any questionnaires, but if there are questionnaires on file, it can return them. And then last updated is for incremental pull. So I can say, since the last time I asked for this, give me any data that's changed in this result. And then measure subscription. So can we use the definitions of measures to actually listen for changes in that set? It's a subscription where the criteria for the notification is all the data requirements for that measure. By defining this in terms of a measure, by saying what I'm subscribing to is the measure, we're actually allowing the implementers of that system to decide how they want to return that. So the implementer could manually say, look at the query and say, yes, we can support subscription to a particular measure, breast cancer screening, because we know that what we're going to return is these procedures, right? And then they can manually put in hooks into that specific system, right? It could be based more generically. It could be if they can tie into the data access layer. It could be a completely generic feed that just said we can support any measure that tells us the data requirements, because we'll just subscribe to those data requirements. And then it also allows them to decide how, what frequency they actually want to notify on. It could be immediate, but they could actually queue that on a daily or weekly basis. So it puts control of how that notification happens into the hands of the implementer. All we're saying is that we want to be notified whenever this data changes. So we prototyped this with a mock MRP discharge measure. So this is a case where when there's a patient discharged from a hospital, within 30 days there needs to be a follow-up reconciliation. There's coordination that needs to happen because the reconciliation almost never happens with the same provider that actually was over the discharge, right? They're discharged from a hospital, and then they have reconciliation within, maybe sometimes the patient isn't even present, but they have reconciliation at other clinics. And so, you know, it's a transition and coordination of care. It would be great to be able to listen to that measure so that any provider that sees within that network that this patient has had a medication reconciliation, now the payer can follow up on that measure. So the idea is then that the EHR, the payer would actually subscribe to an MRP measure. The EHR notifies the payer of a change in the data of interest, so a MedRec is performed, and then the subscription is fired. Then the payer requests the data since that last updated via that collect data operation. Right? They actually can pull that information. And then the EHR responds with a measure report containing all the MedRec data for that patient. So another thing that we're looking at is QDM mapping. Quality data model is the conceptual clinical data model that's used to express ECQM program measures. And all of those, like HEDIS measures, CMS program measures, are all expressed in terms of quality data model. So we built a QI core implementation guide, if you've been following that. It's a set of profiles that derives from US core, but it provides extensions and profiles that support the data defined in QDM. So the profiles themselves contain mappings back to QDM. So if you look in the structure definition, there are actually mappings back to QDM. They're fairly skeletal, but they're there. And then the IG itself contains a QDM to QI core mapping. So if I'm coming from QDM, what is the QI core profile that I would use to represent this information? So one approach to using these mappings is to say, can we do a QRDA-on-FHIR? Can we take a QRDA document that an existing EHR can produce, and can we use those mappings to create a set of equivalent FHIR resources? So category 1 would be patient data, and category 3 would be the summary data. Category 3 would be pretty straightforward because that would just result in a measure report with some counts. But category 1 would mean that you're actually translating the patient's data from the QRDA representation into FHIR resources. So the idea is, can we leverage some of the investment and infrastructure that existing EHRs have to produce QRDA to get some of this data? So that's the question there. And then the other way is the other direction. Alternatively, can we use the QDM to QI core mappings to actually run a measure against a FHIR server? So then in the CQL, we would see encounter performed in the inpatient, and what we would do underneath is turn that into a FHIR query to say, give us encounters in the inpatient value set where the status is complete. And then we return that as QDM data to the engine, and the rest of the measure runs as it's intended. So this is a major focus of the next Connectathon. So we're actively seeking participants. If you're interested, come help us try it out. So just some resources. The opioid implementation guide from yesterday, if you were in that. The HEDIS FHIR implementation guide. This is NCQA measures. There are 11 of them now, I think. They're the 2018 specs, and they're fully specified against FHIR. So those are there. We also have a publicly available test server that implements these and can run these and runs the decision support that we talked about yesterday as well. And there's a publicly available CDS hook server there too for testing. So Also on the site, there are some walkthroughs. For this one, the quality measure processing walkthrough, there's an evaluation there, walks you through setting that up and actually getting an evaluation using these tools. So that's what I've got. Questions?
What was the motivation for creating an implementation guide for HEDIS separate from QI4? And do you expect that every quality program, as you go to more, will have their own implementation guides that developers and EHRs have to conform to?
So with HEDIS in particular, they have different value sets sometimes because they're dealing with clinical or with claims data rather than clinical. So they're not always able to share the same value sets between the program measures and the HEDIS measures. There are other just kind of logistical and differences between those that result in NCQA is furthering and exploring in this way, and this isn't like, let me back up on that. This is a draft. This isn't like, right? This is prototype work because FHIR itself is just now going normative, and so we're not, NCQA with this implementation guide is certainly not saying, you can report and we'll certify with this. But they are saying we're interested in supporting this direction, and so this is a test and an environment where people can participate. So there's, for example, a digital quality summit at the end of this year that NCQA is sponsoring. Using this implementation guide, what can we do? What are the barriers, and how can we remove the barriers? Because we want to move towards this world where we have claims data and clinical data all expressed in the same syntax, but getting there is still a journey. So the QI core implementation guide is kind of the same thing. We're looking at what we want to have is a full stack that supports quality measure, reporting, and evaluation in FHIR, but the current CMS program measures are still using QDM. And so they're still, based on that QRDA document architecture that the current EHRs support. So the focus of that Connectathon track is then to say, how can we build a bridge along that? How can we leverage the investment that EHRs have already made in producing QRDA data to help us get to FHIR? So does that help?
Yeah.
I mean, I know I didn't answer the question, but to be honest, it's above my grade.
Anything that scales effort-wise with number of quality programs or number of quality measures ends up becoming untenable. So
Yeah, completely agree.
Anywhere that we can have standardized QI core and then figure out a way so that people can manage to that in those versions, we don't have to build things for every quality program.
Absolutely, completely agree. And more than that, the HEDIS implementation guide, if you look, those profiles are actually derived from QI core. So we're on both sides of that, trying to push in that same direction. Totally agree. All right, any other questions?
Yes, sir. On that topic, is the fact that have one might accommodate different attribution models across different programs?
So the current ECQMs are almost silent on that, right? Like they just kind of say, you have a population. So that's a really important question. We are actively seeking input on that. There are currently some issues related to that.
I'd like to talk to them about that.
But yeah, it's definitely something. With the patient list in particular, if you run this with a practitioner, it will just use the primary care provider as specified in FHIR. But we recognize that that's kind of a best case scenario, and there are lots of different models for doing that. Right now we leave it out because there's so much variability that we don't want to prescribe what that mechanism is. But
I know
I mean, so that's still under investigation. You know, when we started this, that was the overall goal, was to, you know, you have decision support and you have clinical and you have claims, and there are all these different models, and we would like to get to one place where we can distribute an ECQM and know that it's going to work properly wherever it's evaluated, and we can share that logic between decision support and quality measures. So the first step in getting there was just to standardize on the logic that we use. In this annual update, we've switched to CQL to use in the program measures. But we kept the QDM data model constant because we didn't want to change everything all at once, right? But the idea is that then the engines then give you a way to pivot the model so that, you know, longer term, you can evolve and adapt to what the industry is actually using. When we started, FHIR was STU1, and so you know, it didn't make sense to say, yes, let's use that at that point. But FHIR is getting to the point where it's, you know, yeah, it could support that, and so we're actively working to create standards that support the use. But as far as weather CMS, you know, they haven't said anything about that so far. And that's above my grade. I just make sure the standards are there. All right. Any other questions? Okay.